Today, I'm going to discuss stroke recovery. This title will become a little bit more clear. It's a little bit vague right now, but it will become clear as we proceed. The overall objectives today are to provide valuable information on stroke recovery and rehabilitation, to provide valuable information on the prevention of additional strokes or how to prevent recurrence of strokes, and the importance of movement and exercise for recovering stroke survivors. That will include post-stroke exercise programs, specific exercise.
I think I lost your slide presentation, Dr. Cochrane. I'm so sorry.
Oh, that's okay. Let me see. Let me go back to sharing. Let me go back to screen 2.
There you are. Perfect.
We're back on track?
Yes, ma'am.
Okay, fantastic. So I'm just going over the objectives so that to provide valuable information on that third bullet down and the importance of movement and exercise for the stroke survivors. That would include some post-stroke exercise programs, some specific exercises, and in particular, fall recovery. Next is to educate and reinforce key points to target audience, including stroke survivors, their caregivers, and really anyone who is curious to learn. And finally, to deliver this information in an easily comprehensible, non-academic style. I was told to not make this an academic lecture, so I did my best. I remember doing this as a resident during my TBI rotations, and I had a lot of fun with it. So let me know how I do. So in order to accomplish the objectives we just reviewed, I've chosen to discuss and review with you a really wonderful resource called Hope the Stroke Recovery Guide. And what this is, it is a 66-page booklet that was published by the National Stroke Association in 2016. The National Stroke Association, so you know, is a nonprofit healthcare organization that was formed initially in the United States in 1984, and whose initial mission was to reduce the incidence and impact of stroke by developing education focused on prevention, treatment, rehabilitation, and support for all individuals impacted by stroke. That's a tongue twister. Just for your edification, in case you go on to do more research, searches, etc. As of 2019, the National Stroke Association officially became part of the American Stroke Association, which is a division of the larger American Heart Association. So this booklet is still very much pertinent, and it's really a trustworthy source. In fact, we give these booklets out to our stroke population here at Halifax Brooks. So the guide itself, this Hope Stroke Recovery Guide, is actually divided into 4 sections. The first section addresses important post-stroke issues and offers suggestions on how to address related concerns. Section 2 relates to self-advocacy and shows you how to be an active participant in your recovery, which is super important. Section 3 relates to stroke prevention and offers information on stroke awareness, symptoms, recognition, and how to decrease your chances of having another stroke. And Section 4 has to do with movement and exercise, and reviews sample programs to help you, the post-stroke survivor, gain strength and range of motion. Let's see. So this, to be firm, this outline of today's presentation is shown here and largely follows the structure of the Hope Recovery Guide. We will begin by discussing the post-stroke recovery process and what that entails. We will then shift to the theme of self-advocacy, specifically as it pertains to the stroke survivor. Next, we will highlight the vital topic of preventing recurrent strokes. And finally, we will discuss the role of exercise as part of an individualized post-stroke therapy program. So to begin, Section 1. So let's start at the beginning of the recovery process. So the goal of stroke rehabilitation is to restore as much independence as possible by improving physical, mental, and emotional functions. And this really needs to be done in a way that preserves not only one's dignity, but also motivates the survivor to relearn basic skills that the stroke may have affected. These things are activities such as eating, dressing, and walking, things that we take for granted, really on an everyday basis. Rehabilitation should start as soon as possible after the stroke. You see a lot of therapists moving into the ICU setting to get the patients mobilized. And so really the key is to start as soon as possible. However, the stroke rehabilitation options will depend on several factors shown here, including the ability to tolerate intensity of rehabilitation. That's part of, during a physical medicine rehabilitation residency program. That's why we have 2 rotations dedicated to consultation. We really need to assess the patient for their tolerance of this in terms of acute and patient rehabilitation, 3 hours of aggressive therapy a day. Also, we have to consider the degree of functional status and impairments, any available funding, the patient's insurance coverage, and the geographical area. So the following chart reviews the major rehabilitation options. So the key is stroke survivors who qualify should receive treatment in an inpatient rehabilitation facility, or IRF. This is in preference to a skilled nursing facility. And the reason for that is, as you can see in the chart, there is more intensive therapy in an acute inpatient rehabilitation facility, such as Brooks Halifax. That's why the stars are in the upper left-hand, 1 star in the upper left-hand corner corresponding to the star in the lower right-hand corner, because Halifax Brooks is an example of acute inpatient rehabilitation. You see a doctor every day. You have the intensive rehab program, which is at least 3 hours per day, 5 days per week. Sometimes that will run over to the weekends. A skilled nursing facility, not so much, as you can see in the chart.
I think that frequency is really important, right, Dr. Cochrane?
Absolutely. Studies have shown, and again, because I was told this was not an academic lecture, I did not include such studies, but they're very well known, and it demonstrates that a patient who has survived a stroke, they will do better in this more intensive environment versus going home, or versus going to an outpatient clinic or nursing home, for example. Exactly. So we really want to get the patients in. So the American Stroke Association website provides a plethora of super helpful resources, including tips for choosing a rehab facility. And I just wanted to include this here. This is just some poignant points that the website depicts. So really, when you choose a rehab facility, the question really becomes, and it's the bottom of the screen, is your program patient-centered? And if so, what are the ways in which it is? It is key that when you go through one of these programs, that you are integrated into the rehab team, which you will see in the next slide is comprehensive, and that you and your loved ones are listened to. So it's really a nicely well-oiled machine. So this slide shows the different players in the friendly rehab team. This is mostly related to the acute and patient rehabilitation setting. And a couple points too that I always want to emphasize to every patient is that it's really important to get to know this healthcare rehab team and feel comfortable addressing really any recovery issue with us, right? This is what we are here for. It's rehab is a little bit different than most other aspects of the hospital. We really want to empower the patients, loved ones, families, etc., to take action, and this will be related to the self-advocacy section. But we want to make sure that your questions, your anxieties, your concerns, whatever it may be, are communicated clearly so that we can help you with them, because that's what we're here for. And that's why I went to school for 35 billion years, because I want to be able to help people. There's nothing like being able to help someone and see their level of anxiety relax after going through some of their really important questions, because it's anxiety provoking. You have to understand, I'm a spinal cord injury specialist, but you have to understand that every person who's in Halifax Brooks has gone through a major life-changing event. So
Yeah.
That's why we really emphasize the importance to anything you want to talk about: peeing, pooping, sexual function, whatever. You got to get that out there. That's what we're here for. So So discharge planning is the process of preparing you, the post-stroke individual or stroke survivor, to live independently in the home. And the purpose is to help maintain the benefits of rehab, again, referring to the acute inpatient rehabilitation period, after you have been released from the program. So for example, we start discharge planning on day one. That's one of the tenets of physical medicine rehabilitation, inpatient rehab. We have to start thinking about. So I talked about the rotation as a resident doing the consults. Second we meet that patient, we have to start thinking about discharge planning. So it's a long, sort of arduous process that is not always as straightforward as it appears. But the point is that it begins very early during rehabilitation and involves you, the survivor, your family, and the stroke rehab team. And it's really important to keep in mind that inpatient rehab, like Halifax Brooks, helps a patient to be safe to return home, but it doesn't address all of the functions and rehabilitation needs a patient has. So relatedly, you have to consider that every patient's recovery is different and unique, but often textbooks will say stroke recovery takes 3 to 12 months and often beyond. And to maintain the gains in work, to maintain the gains that a patient has achieved during this acute inpatient rehab stay, the patients really have to continue to work at their recovery going forward, meaning they have to keep up with their exercise program, they have to do their homework. So let's see. What does discharge planning entail exactly? So discharge processes differ from facility to facility, but most commonly involve the following points. Making sure you have a safe place to live after discharge, making sure that you have all of the correct equipment that you'll need at home, the rehab services or other services in the home will be prearranged for you. You'll have all your healthcare providers set up for you. You'll have the caregivers identified and trained. That's why we do family training here at Halifax Brooks. And also determining which community services may be helpful for the stroke survivor. So there's a lot that goes into this. And that's why thinking as a physiatrist is different than, just an internal medicine provider, for example. So next, I'd like to touch upon the importance of socializing. And this social support concept is really a vital part of stroke recovery. And whether it be with friends and family or via a stroke support group, such as this virtual group, basic human interaction is a very powerful means of support, and provides a great deal of healing for the stroke survivor and their family. So there are many ways to get the support you need. And again, I'm going to reference this many times, as I have already. The American Stroke Association is an excellent resource. I mean, you can spend all weekend on that website. So I've also included additional resources at the end of the presentation as well.
That's one of my favorite go-tos for any information.
It's absolutely phenomenal. It really is. So in this slide is taken from the American Stroke Association website, and all you really have to do to find a stroke support that's near you, you plug in your zip code, and it will pull up a bunch of hopefully a bunch of support groups. If not, you contact them, you talk to someone, and they will one-on-one find a stroke support group that will work for you. So you can spend time with family and friends, and that's great. And here are the pluses, on the left side. Sometimes either family and friends are not available, or you just want to turn to someone else, sort of someone you have not had any kind of relationship with before, and that's sort of a support group. And sometimes people are more motivated by strangers who, as per the last bullet point, can become your new friends. But sometimes people are often more motivated by initially strangers than by their own family and friends. So if you have both available to you, I recommend you take advantage of both social support systems. So when it comes to discharging from the rehab facility, stroke survivors are often, I would say, well, it's not just stroke survivors, anyone leaving acute inpatient rehab have some anxieties and are a little bit apprehensive about being at home on their own. Now, when I say on their own, are they going to be there by themselves totally? No, not necessarily, but I mean without having 24-hour supervision, without having a physician, without having their therapy team to work with every day. And so this slide depicts very common fears that these patients may have. Thoughts of a stroke might happen again. You may realize the extent of your disabilities and be unable to accept them. These lead to feelings of anger, agitation, depression, anxiety, tension. Again, I will hopefully drill this into your head. The point is, talk openly with your doctor, your family, your therapy team while you are in the rehab program, so that your anxieties, your fears, concerns can be lessened. And also it's important, easier said than done, but it's with trying to keep a positive attitude. Things in keeping an open mind, things will be a little bit smoother. I should take my.
Well,
uh-oh.
That was you.
This is my Halley cat. Yeah.
You have to go to that.
I'm sorry, audience. I have an emergency situation with one of my patients, so I'm going to see if my medical director can handle it. But could you pause for?
Yeah, we can take a moment, and I can pick up from here as far as this conversation is concerned.
Okay.
So,
Thanks.
So as the unfortunate component for Dr. Cochrane is she is actually on duty today. So it's interesting to see that they do have emergent situations that they have to attend to. the main focus that she was talking about is that the caregivers will be able to anticipate your needs and your thoughts, but may not be able to understand wholly how you're feeling. So please feel comfortable to share those thoughts and concerns that you have so that they can possibly be addressed and managed. Some stroke patients can be very depressed and may need extra support, maybe medication in the mid-time to carry them through to be able to do their physical therapy. It is something that's very important because the physical therapy component will help the patient be able to strategize how to do their activities of daily living with the support of that internal team or with the support of a team that is at their home, depending on how well they're able to manage their care. You may need caregiver support, and there's a lot of caregivers that do a lot for their stroke survivors or their stroke patients, whether it be their mother, brother, sister, loved one, whoever it may be. It can be very challenging for the caregiver as well. So being able to have that additional support for the caregiver is awfully nice to be able to utilize the team while you have them to ask about where can I, as a caregiver, find a support group, because they do have those as well, especially on the American Heart Association website that Dr. Cochrane had referenced earlier. So there's so many resources available that a lot of times post-stroke patients may not be aware of, because, you know, most people wouldn't consider researching what can help me with a stroke before they've had one, because stroke is kind of something that occurs out of the blue. It's not something that kind of builds up over time. So it's a sudden event that occurs that can really change someone's life pretty significantly. So I'm thinking that Dr. Cochrane may not be able to get back here unless she might be heading this way soon.
Okay.
There you are. Yay. Here's our to go dead.
Okay. So thank you for sorry about that.
No problem. That, you know, I explained that these things happen and it's important. You go and attend to them.
Yes. Although the nurses here are phenomenal. So so they just needed me to really not do anything. The nurses are absolutely phenomenal here. Okay, so we're talking about going home. So in regards to going home, you may find that home modifications are warranted to fit your needs. And that's why here at Halifax Brooks, our therapy team often performs home evaluations exactly for this purpose, to find out what needs to be changed, what we can keep, what needs to be rearranging. So these home modifications may entail renovating the actual structure of the home. For example, modifying the home so that narrow doorways, stairs, and bathtubs do not interfere with the patient's ability to manage personal needs. The alternative to this costly renovation plan is to modify the home environment, which, for example, might entail removing barriers and adding assistive devices such as ramps and grab bars. And again, our team can make those recommendations easily. And then shown here are just several examples of links to articles and other multimedia on helpful tips relating to home modifications. And again, these links are all part of the American Stroke Association website. Okay. All right. So that has to do with, stroke. I'm trying to get this. with home modifications. We're going to shift gears to the modifications that may be necessary in terms of your activities of daily living. And as we all know, especially those who are survivors, stroke can make everyday activities extremely challenging. And these challenges can be due to a number of stroke-related conditions, such as limb weakness, numbness, paralysis, communication challenges, vision challenges, one-side neglect, homogenous hemianopsia, et cetera, et cetera. So routine everyday activities that we take for granted can become very, very challenging. These tasks, including getting dressed, even making a sandwich, even doing your laundry, become major obstacles. And again, this is from the American Stroke Association website. The website provides some tips, helpful hints and recommendations and gadgets that might be helpful in modifying or making your activities of daily living a bit easier. So, for example, they discuss meal preparation. And for example, they point out that dishes in pot lids can be stored vertically for ease of, for accessing those types of things and storing them. If the countertop is too high, as another example, they recommend substituting workspace that can be made by opening a drawer at the desired height and placing a cutting board over it, or by using a wheelchair lap board. They're quite creative recommendations. Let's see. Related to that, the American Stroke Association does a wonderful job at providing details and guidelines or recommendations for eating well after a stroke, because that is super important to your recovery and especially towards secondary stroke prevention.
This is a hot topic. I want to try to get someone to talk about it more in depth than just one speaking. This is that food modification, diet modification is huge.
Absolutely, absolutely, and it's not easy to do.
No.
So in terms of dressing and grooming, so we all know that dressing oneself is a basic form of independence, and the added value of being neatly dressed helps promote your self-image, for most people, for some people, I should say. And what this slide depicts here, again, these are all hyperlinks. So on the leftmost box bordered in green, those blue bullet points are all hyperlinks to dressing tips, shopping tips, bathing tips, driving after stroke. So again, a plethora of information. What is shown here is a device in the middle to help button your, looks like a button down Oxford when you have one hand, your other hand is a little bit weak. And that's super frustrating if you ever tried to button a button with one hand. The rightmost image depicts a long-handled shoehorn to help slip on shoes.
Very helpful.
And the list goes on. I mean, it is, again, that could be a whole other topic in the, yeah. So this topic, still in this section though, relates to post-stroke pain. And it's very, very common to experience pain of some sort following a stroke. Common causes, you can see on the left, it's really that shoulder subluxation is what we see a lot. That shoulder subluxation, meaning the humeral head, which is the like the bony end of your arm bone that fits really well into the glenoid fossa, or the sort of that cupping of the scapula, which is that triangular bone on your back. Those muscles, ligaments, and tendons weaken after a stroke. And so because of that, you get this subluxation, the humeral head. There's a little bit of space between the humeral head and that glenoid fossa. And that causes pain. That pain can set up a pretty vicious kinetic chain of pain that involves, upper traps, your occipitals. It can go into your ear and it can radiate down into your hand. So that's a pretty common presentation. And people will describe the pain as mild to severe, constant or intermittent, aching, burning, sharp stabbing, or itching. And the key really is to figure out what is causing the pain so that you can treat it. This is not up to you, the person who has had a stroke. Your job is to go to your physiatrist or whoever's treating you. Go to your therapist and tell them about this, and it's up to us to figure out really the primary nidus of the pain, so that we can break those kinetic chains and treat the pain effectively.
Perfect.
And that's what this slide has to do with. Has to do with pain internment. And really, you can think of it just as your rehab team is interdisciplinary team, multifaceted. The approach to post-stroke pain is also multifaceted. Oftentimes it's going to take a lot more than just a steroid injection or an oral analgesic agent or range of motion exercises. It's going to be a conglomerate of all of the above to successfully treat this pain. The big yellow obnoxious star is a reminder to every person who goes to the doctor, probably with the exception of doctors, because we don't go to doctors, but is to bring a list of your medications. It's better to bring bottles of every single medication you're taking. Lists, people put whiteout on it, they spill coffee on them. Bring the bottles of medicine so that we can see exactly what you're taking. And if you're taking any herbal supplements or over-the-counter stuff, whatever, we want to know about that too. Tell us everything. So most people consider the ability to drive as an essential activity of daily life, right? It provides us with an easy way to get around. It gives us a sense of independence and self-assurance. Believe it or not, it's a pretty complicated activity, which requires multiple levels of information processing as well as mobility. We sort of, again, we take it for granted because it becomes an automatic task for us, right? Like walking, like, feeding, whatever. So in many cases of post-stroke survivors, it is possible to regain the ability to drive a car safely. In fact, a lot of people will present the statistic about 80% of stroke survivors learn to drive again, make it back onto the road safely and successfully. But that's not everyone. And even though you have great functional recovery after your initial insult, you have to go through a formal process to find out if you are ready and able to drive. And that usually entails a driver's evaluation, which includes assessment of functional ability, reaction time, visual testing, etc., in addition to driver's training, which typically includes classroom driving simulation, transfer training, wheelchair loading, etc. And those are just the basics. Sometimes the primary care physician will send the patient to a neurologist to have special testing done, etc. And Sam, correct me if I'm wrong. I believe in the 201 building, Brooks Outpatient Therapy has a simulated driving center for patients to be tested. Is that right?
I have heard that rumor, yes, but I haven't confirmed it's
sure.
in there.
Yeah. Again, if you are someone who has been through a stroke and is itching to drive again, don't just get behind the wheel because, well, I'm not sure. A lot of physicians will take the license away from you. So not a good situation if you get stopped. But it's a safety factor. I mean, you can kill yourself, you can kill, innocent passerbys. So if you are itching to get back to driving, again, there are resources on the American Stroke Association's website regarding how to find out where these driving centers are. Again, always ask your.
They're around. They're definitely around.
Yeah, and it's important to note that just just because there are like the driving school centers like that we went to when we were like teenagers getting our license, those people may not be trained to deal specifically with post-stroke individuals. So it really needs to be a specialized testing center. So if anyone needs help figuring this out, reach out to Sam or myself. We'd be happy to help you. This just shows some adaptive equipment. So on the left is a spinner knob. And what that means is it's usually used in the setting if one hand is very weak and it's not reliable to grip the wheel. It's attached to the steering wheel as shown in the picture, and it allows you to steer the car easily with just one hand. And then, sorry, that's the left, I might have said right. On the right, the image depicts a directional signal extender, which is really helpful if you are someone who's unable to use your left upper extremity with accuracy. This extender may be helpful. Okay, switching gears now to dealing with emotional changes after stroke. So I thought this was pretty interesting and I wanted to include it. There is a post-stroke, and again, this does not pertain to every single stroke survivor. However, it's fairly well documented that after surviving a stroke, this grieving process or a pattern similar to it may be experienced not only by the survivor but also the family. It's sort of that ripple effect. And a lot of people say, I feel like I'm on an emotional roller coaster. This is totally normal. So it usually the what sort of hits the fan here at rehab, because you have just come from, the ICU where you live minute to minute to minute, or, a step down unit where, it still is, you live hour to hour, right? You finally have received some medical neurological clearance to come to rehab. And now you're faced with performing these tasks that easy peasy, right? But you have a hard time doing them. And this is when this sort of grieving process takes place. So just briefly, this grieving process really can be considered a gradual healing process that takes time and work. You got to work through it. That's why physiatrists, we not only focus on the physical aspects, right, but it's also the psychological and emotional aspects of a human being as well, just as important. So, stage 1 is shock, and that usually occurs during the initial phase of hospitalization, or as I said, during rehabilitation. It's usually a feeling of helplessness that may accompany the shock, and it's been well documented that during this time, especially, the support of family and friends is very, very important. Denial is the second stage, and this is not really being able to believe that something terrible has happened. Denial offers the stroke survivor and their family a psychological way to escape the overwhelming aspects of the disability, right? Stroke is a short word, but it has great, far-reaching implications in all aspects of life. Stage 3 is reaction. And this stage begins when the stroke survivor and or family start to realize the full impact of the disability. The most common psychological reactions are anger, bargaining, depression, and then eventual mourning of losses and changes. And if these reactions interfere with rehab or usual activities, it's important to be evaluated and, if necessary, treated by a mental health professional. And that's why we have the neuropsychologist on hand and the rehab psychologist to help us with this. Stage 4 is mobilization. And this, they say, is a stage where you, the stroke survivor, may say, okay, something awful's happened to me, but I want to live. So show me how. People or patients might be a little bit more eager to learn. So this is often a good time to try to integrate or to initiate community outings, which again is what we do here at Halifax Brooks. Stage 5, the final stage is acceptance, right? Which is the final stage of the grieving process. It's when you, the survivor and or your family, learn to live with the disability the stroke has caused. And it's helpful in moving forward. Okay, next is, so relatedly, I just wanted to touch base on the changes in behavior, emotions, and thinking that result from a stroke. And it really, these changes can be bewildering. And all of a sudden, the patient can seem like a completely different person than the one you knew before for many, many years. In a sense, this is really true and accurate. It's true and accurate because the stroke survivors' brains have been injured, and the behaviors and the emotions that they may display can be a reflection of that injury. That's why understanding and dealing with these changes are just as important as the physical issues that are dealt with, in physical therapy, occupational therapy, etc. And obviously, this is Munch's The Scream, which was composed in 1839. One of my favorite paintings. In person. So, depression, post-stroke depression, is very common after stroke, and it affects about one-third to two-thirds of all survivors. They can be mild or severe, often starting in the early stages of stroke recovery. It's really important that stroke survivors be assessed for depression and treated when it occurs. It's important to identify and treat the post-stroke depression as soon as possible, because it can lead to more significant and severe issues such as suicide, self-harm, harming others. I have found, just as a side note, that especially with patients who come to Halifax Brooks of the older generation, they are much more hesitant to start an antidepressant versus someone who's a little bit younger. And I've just in having conversations with my own family and their friends, there is a lot of stigma against mental health, and there just should not be. So a lot of the counseling that you will most likely provide as a inpatient rehab physiatrist is breaking down those barriers. Some people will get there eventually. Some people will just say nope, and that's fine. That's their right. So anger and resentment are also really common for survivors after their stroke. So a lot of some survivors may express their anger more openly via being critical of others, especially those very close to them. So it's really important that when a survivor becomes upset, the caregiver should keep their emotions in check. It is second nature. It's a knee-jerk reaction that when your loved one starts to display these feelings of anger and resentment, swearing and really, really hurtful language, you've got to keep your own emotions and your own reactions in check, right? It's okay to sort of step away from the situation for a little bit. And then it's important to, when the survivor sort of has calmed, to state in a very sort of black and white, simplistic manner, something positive, something that shows understanding, like this on the screen. I know this must make you really angry. Let's see if we can work through it together. That's really difficult, very, very difficult to do, especially if you've had experience with this. So pseudobulbar affect is also known as emotional lability. It's actually a physical brain condition or change that causes spontaneous, uncontrolled, and emotional reactions. Like when, for example, a stroke survivor can spontaneously burst into tears or laughter for no apparent reason, and that's not typically socially acceptable. The frequency of this occurrence is greatest in the first few months after the stroke, and we see that it gradually fades over time. And this just shows or depicts the best approach for dealing with emotional lability. Again, it's to accept the behavior in a matter-of-fact manner if you're the caretaker. Next is anxiety. Of course, many changes, far-reaching changes related to stroke can lead to worry and anxiety. Things like financial strains, fear of falling, speaking to your family, speaking on the phone, going to the bank and trying to communicate with the teller. Just simply getting around the house. All of these things shoot your anxiety level, or very commonly shoot your anxiety level through the roof. Again, if you are a patient who has experienced a stroke and is feeling super anxious, please let us know, because we can help you. So often, very common following a stroke are problems with memory and concentration. And in particular, social situations can be especially difficult for people with these problems. And I saw this in particular with my father, who is an exceptional human being. Unfortunately, he suffered from a stroke several years ago. My father is he's a charismatic, charming, brilliant. He's someone who, when he walks into a room, there's a lull in the conversation because everyone stops and stares. So when he went through his stroke, the social aspect of his personal and social life was really impacted for a while. And it was my mother who really had to sort of help him through these situations. And that is in reference to the fourth bullet point. If your loved one now has trouble recognizing acquaintances or remembering names, you can finish reading that bullet point. For example, my parents never really, slowed their social calendar for a very long period of time after my father's initial event. And so my mother would sort of have to feed him clues or help him to interpret the environment, which he never had to do before. So that's really important. Okay, moving on to self-advocacy. So advocacy means active support, especially the act of pleading or arguing for someone. Now, it's a little bit different to be a self-advocate, right? Because you are doing this for yourself, right? That's why I want everyone who comes into Halifax Brooks to be an advocate. I want you to speak up. I want you to say, hey, look, I didn't really like that therapy session. Hey, I really didn't like the sleep medication you put me on. You have to be a self-advocate. What's really important is taking a positive approach to your recovery. In fact, a lot of people or the American Stroke Association say that that's the single most important step that anyone can take. Really, it's important during the self-advocacy process to remember that recovery is a lifelong journey, but it is imperative to stay positive and make sure you stay the course. So some self-advocacy steps include prevention of a subsequent stroke. That means we'll talk about that a little bit later. You're going to take these steps necessary as prescribed by your doctor to prevent another stroke. This includes things like monitoring your blood pressure, take your medications, stop smoking, et cetera, et cetera. Educate yourself, obviously. This is, God's gift to the world is education. And then again, ask questions, ask questions, ask questions. You're not obnoxious. You're not annoying. We're not going to, stop liking you. You've got to ask the questions. So there are many considerations which go into planning for your care after hospitalization. Your needs and the resources available to meet these needs are key. And the American Stroke Association offers key questions that are recommended for consideration as you and your caregivers prepare for life post-stroke outside of the rehabilitation facility. And it's really important to try to address the following questions in an open manner. And so let's proceed. So determining wants and needs. So in terms of the physical realm, physical wants and needs questions include, for example, can you transfer from a wheelchair to a bed independently? You can read the rest on your own.
Very important items.
Super. Questions related to emotional wants and needs include, have you experienced emotional difficulties in the past or present, such as severe depression? If so, what kind of special care is needed, et cetera, et cetera. Questions related to anticipated improvement include, what is your potential for improvement in each of these areas? What follow-up services are required to achieve the goals? And it's often difficult to come up with this on your own. So that's why you should talk to your rehab team, your multidisciplinary rehab team, to help you to help set the stage to answer these questions. So questions related to financial wants and needs may include, what are your financial resources? What kind of insurance do you have? Some people have great insurance, which will cover, a bunch of DME, a bunch of post facility programs. Some insurances are really, really the pits. Let's see. Questions related to caregiver needs and limitations may include, how does the family feel about caring for you? Is the time spent together rewarding for all involved, et cetera, et cetera? These things you can go through at a later time. So goal setting is really, really important. And I mentioned this before, but, in everyday life, all of us rely on our work, our family, our community activities, our relations with others, as well as on our hobbies and interests to give us or to provide us with a sense of purpose and self-worth, right? But after one suffers a stroke, they may find that the physical changes, that some physical changes require you to develop new interests and involvement so that you can continue to feel good about life under these changed conditions, right? Developing these new interests, strengths, and abilities will be made easier by setting long-range as well as short-term goals. And a good way to achieve these goals is by planned daily activities. So you sort of work up, right? You start by making planned daily activities. Make sure that they're achievable, right? I always, whenever I want to lose weight, I want to say, my goal is, I'm going to lose 30 pounds by the end of the week. That's just not feasible. Maybe the goal is to daily plan activity. I start to walk, 10 minutes a day or something like that. It has to be something that is realistic in addition to being flexible and also measurable. So in thinking about setting these goals for you, right, it's important to consider these four main areas. Again, these are just recommendations by the American Stroke Association. So you have your short-term goals and you have your long-term goals. Just as, starting from creating daily goals will lead up to short-term goals, will lead up to setting long-term goals. These will help you become more integrated, or at least it's one way to become more integrated given your new differences and sometimes challenges that a post-stroke patient faces. So I just wanted to include this. So when we encounter unusual periods of stress in our lives, problem-solving methods which worked in the past can begin to break down following stroke. Sometimes stress makes even small problems seem overwhelming, and that's why I've included this slide to help sort through problem solving. It seems a little elementary, but if we just return to basics, oftentimes it can be tremendously helpful. So this section, the third section, is in relation to preventing another stroke or preventing recurrent strokes. So everyone has some stroke risk, right? But there are two types of stroke risk factors. One type you can't control, and the other type you can control. Things that you cannot control are increasing age, your gender, your race, your family history, prior history of heart conditions. Modifiable risk factors, you'll note that the list is longer and may appear on the left. And it's it's important to know that each stroke survivor has their own unique set of risk factors that contributed to their stroke, right? And so knowing the underlying cause of your stroke is really important to preventing another one, right? I mean, my father, obviously, I revere him, but he, healthiest person, healthiest 70-something-year-old, bam, he had a stroke. Turned out he had uncontrolled hypertension. Who knew? Exercises daily, fit, etc. This has to do with lifestyle choices. So this has to do, go back to the other slide, the left-sided modifiable risk factors. How can you take these modifiable risk factors and do something with them? This has to do with the lifestyle that you lead. Do you want to be like me and go to Publix after a really stressful day and eat, 5 pints of Haagen-Dazs ice cream? Or do you want to save going to Publix and, spending that? Do you want to go to the gym and get your steps in? Really, the choice is yours. And here are some of the most important recommendations that the American Stroke Association highlights. So again, because every stroke survivor is unique, it's really crucial to work with your physicians and also the other members of the rehab team to prevent another stroke. So what's that? Oh, sorry.
No.
So the physicians will tailor a medication program that's unique to you. And so these are just some of the common reasons why medications or a pharmacologic regimen is prescribed. It has to do with preventing blood clots, preventing seizures. Not every post-stroke patient is susceptible to seizures, so that's why you really need to figure out what kind of stroke, hemorrhagic, ischemic, and location, frontal, parietal, temporal, etc. Because the types and locations are more prone to seizure activity after a stroke than others. Also reducing blood pressure and cholesterol, that's huge. If you have diabetes, you got to manage that. If you have AFib, you got to manage that. And again, managing depression. There are numerous pharmacologic options out there, and really that works best with therapy. This is just a reminder that adherence is critical. Do what your mom told you when you were little. Do your due diligence, and really, the onus is on you. But don't forget, your life really depends upon it. So this has to do with signs and symptoms of a stroke. Please keep in mind that stroke is a medical emergency and every second counts. So on the left shows common signs and symptoms of stroke. If you see any or if you recognize any of these, do not pass go, or whatever that Monopoly saying is. You got to go. you have to act fast, call 911, and get help right away. So this is a great acronym. So in order to spot stroke signs, use the letters in FAST: face drooping, arm weakness, speech, slurred speech, and then T is time to call 911. You have to, this is not something that you say, oh, well, I guess it'll pass. No, any of these things, this is not a joke. You get on it. The worst thing that happens is you show up to the ED and you're diagnosed with a mosquito bite or something. But you know what? It's better to take the risk of, overcalling something than undercalling something. I've had patients who've presented to acute inpatient rehab who have waited. I couldn't really talk. My arm was weak. I waited a couple of days there. So really that lags the onset of acute management. And also the hands-on time with the rehab specialist. Okay, final section, movement and exercise. So let's see. So movement is really impacted by insults to the brain, right? These problems can range from balance issues to frank paralysis of the limb, to spasticity, etc. As a result, about 40% of stroke survivors have serious falls within a year of their strokes. And that is key, and that will lead to a couple slides in the future. So we just have this slide shows common physical changes after stroke. You have the muscle weakness, the paralysis, the spasticity, the fatigue. Ouch. Again, exercise. I'm going to sound like a broken record. The American, American Society Association for Stroke, American Stroke Association, sorry, has, again, a plethora of resources to help you get motivated, to stay motivated, and to increase your workouts. As a note, if you are someone who has suffered any kind of primary neurologic injury, you do not just jump on a treadmill and start at full speed. Again, these programs come from a well-trained multidisciplinary team of rehab specialists that tailor your exercise program to you, to your functional level, to your functional goals, etc. So we know the benefits of exercise, but specifically as it relates to patients who may have undergone a stroke, the types of exercises that your therapy team will design for you often lead to requiring less assistance for negotiating stairs, may lead to more smooth and steady movements during ambulation, may lead to improvements in balance and endurance, et cetera, et cetera. So the next series of slides show specific exercises that are commonly prescribed to patients with impairments related to their stroke. For example, in this exercise, this is a common exercise that's prescribed to help strengthen the muscles that stabilize the shoulder. Remember, we were talking about post-stroke pain, and I was talking about how common it is to have shoulder pain because of something called the subluxation, when the humeral head sort of stretches further away from the glenoid fossa. This is an exercise that pertains to strengthening those muscles to reestablish that purchase between the humeral head and the glenoid fossa, so that kinetic chain of pain can be broken. We don't have to go through all of these. I don't know what time it is, but so this is to strengthenize the muscles of your shoulder. This is specifically to strengthen the shoulder muscles as well as those muscles that help to straighten the elbow. A lot of times, well, it's not a lot of times, it is well established from years and years of study that there's a flexion synergy pattern that occurs in the extremities. Again, I'm not going to go into that here, but you have a flexion pattern. You know, your shoulder is adducted, your elbow is flexed, your wrist is flexed, and your fingers are flexed. This is a way to help straighten out that elbow. Again, straighten the elbow. So hip control, you have such powerful stabilizers, lower extremity stabilizers, and core stabilizers in your hips, in your glutes. This is one way to help strengthen them so that you can gain better control for that smooth pursuit during ambulation. Again, hip and knee control. This sort of goes back to physics, that, you know, center of gravity, line of gravity, where that line of pull occurs. You want to make sure you have strong glutes, strong hamstrings, strong quads, etc., so you can get an efficient gait cycle or reestablish an efficient gait cycle. Again, knee motions, weight shift control improvement, improving balance, simulating proper weight shift and knee control necessary for walking. This is when you're a little bit more advanced. And also, this is when you are a little bit advanced, so that you can really help perfect and promote the strengthening of the hip and pelvic girdle muscles. I wanted to include this topic, getting up from a fall, as it relates to the previous comment that I made about the common instance of falls post-stroke. Really, right. Anyone should know how to, you know, should understand the proper mechanics of getting up from a fall. It depends. If you come across someone who's fallen, do not try to get them up. Make sure they're comfortable, right? Make sure that they have a pulse, and then go get help, right? Because they could have fracture. A fracture, an unstable cervical spine. If you try to move them, oh, let me prop your neck up on a pillow, you could paralyze them. Right. So make sure you go get the proper or activate the proper chain of command for that. If you fall, though, here's just simple, several simple steps. So first, you want to, this is you again, you have fallen. Assume a side sitting position with the unaffected side close to a heavy chair or another object that will not move. Again, that assumes you have that heavy object right there with you. Step 2, place the unaffected forearm on the seat of the chair and lean on the elbow or hand, and then you're going to shift your weight forward onto your knees and lift your hips until you are in a kneeling position. That can be pretty tricky. And then supporting yourself with your unaffected arm, bring your unaffected foot forward and place it flat on the floor. And you might need a little bit more time to help with balance and coordination in order to keep the affected limb in the kneeling position while placing the unaffected one in the position illustrated. Step 4, lift yourself up by pushing with your unaffected arm and leg. Twist your hips forward to sort of hoist yourself onto that seat. Again, it looks simple, but it can be a little bit cumbersome. But those 4 steps, show the basic safe maneuver and proper way to get up if you've fallen. So as I said before, there's a plethora of resources. These resources all are from the American Stroke Association website. So you have the Stroke Magazine, the National Stroke Support Registry, various support networks, daily tips for living. It's an archival library. And then you have a hotline, or it's really called a warm line. So you can reach out and talk to someone when you need to. So I just wanted to conclude this presentation on stroke recovery by acknowledging that recovery from stroke is a lifelong process. However, No matter where you are in your recovery journey, there's always hope. And this comes directly from, obviously, the Hope Recovery Guide, and is resonated throughout the American Stroke and Heart Association guidelines and resources. And finally, I would like to thank everyone for your attention. Thank you very much.
Oh, thank you so much, Dr. Cochrane. That was so informative. We had a couple people on the Facebook Live, not a lot of comments, but I think we'll get some information, maybe some interest. I will post a lot of those links on our Facebook support group page, so that anyone watching will be able to click and link quickly to that information, so that we don't leave them hanging.
So that's a great idea. Thank you.
But I would like to thank you very much for your time. Especially, I think there's so many other areas that we can go into to have further conversation for the stroke survivors. Just from this one conversation, that was very awesome. Thank you so very much.
Absolutely. Again, thank you for giving me the opportunity to talk. I'm sure you and whoever's listening know now that I really like to talk, especially if it's something that I am passionate about. Let me know if you have any questions. I'm happy to help you out in any way that I can. Thank you.
Yeah, thank you so much. So I'm going to end the recording, and it'll be available on Facebook Live, and we'll also make it available on our website if necessary. If we have more people who are interested. We had Casey Ryan from Halifax Health Hospice and Care saying thank you very much for that presentation.
Oh, Casey, thanks for tuning in. And Sam, thanks again for organizing all this. Patients really benefit from this. Thanks to you. Thank you.
You're welcome. And get back to those patients now. Thank you, Dr. Cochrane.
Thank you.
Bye.